Hi, this is Dr. Clay Brooks with Real Medicine, and today we're going to talk about DeForest, Buckner, and cervical disc herniations. I did a very short video about him being placed on injured reserve. If you don't know who DeForest Buckner is, he's a Pro Bowl player for the Indianapolis Colts, and he suffered a cervical disc herniation. So we're going to talk about disc herniations, we're going to talk about the cervical spine, talk about treatment options, because in his particular case, he's going to need surgery. So we'll kind of focus on that aspect. Yes, cervical disc herniations can be treated non-operatively. In many cases, that's the first line of treatment. But if non-operative treatment fails and or a person gets worse over time, surgery can be considered. So again, DeForest Buckner sustained a herniated disc. And as a result, cervical disc herniations can cause numbness, they can cause weakness, they can cause a lot of pain. And specifically talking about cervical disc herniations, what we mean by cervical, we mean the neck. So that's the cervical aspect of the spine. The mid portion of your spine is the thoracic spine, related to the thorax. And then the lower portion of your spine, or your low back, that's what we call the lumbar. Even lower than that is the sacrum. But focusing on the cervical aspect, when you herniate a disc there, it can compress your spinal cord, it can compress a nerve, and those nerves are what gives us the sensations and controls the motor functions in our upper extremity. So first of all, when you think about a disc is a soft cushion in between two vertebrae. So if you can imagine this is a vertebrae and that's a vertebrae, the disc is the soft cushion in between. Acts like a shock absorber. And it has like a jelly-like characteristic. Another way to think about a disc, think about a burger. Think about the top bun being a vertebrae, the bottom bun being a vertebrae, and the disc being the patty in between. So that's what a disc is. Soft, jelly-like material that acts like a shock absorber. So as we absorb impacts, we move our neck in certain positions, they absorb, they allow us to have motion throughout the neck. When those discs are injured, then they lose their normal anatomical position. And when they lose their normal anatomical position, they can compress on delicate structures that are nearby. In his particular case, it's being reported that his is ruptured and is compressing on the nerves. So that can cause the symptoms. Now, when it comes to discs, they are made primarily of collagen, primarily two types of collagen. So the disc has an outer ring, which we call the annulus. Then it also has an inner portion called the nucleus, or the center. So again, a good analogy for that would be to think about a jelly donut. So a jelly donut has the outer portion of the donut, but it has the soft jelly portion on the inside. And in the example that I gave, the outer portion of that donut is made of type 1 collagen. The inner portion of that donut is made of type 2 collagen. So when the type 2 collagen, or the nucleus, when it ruptures out, spits out of the normal area where it's supposed to be contained, it can compress nerves. Now, one of the issues with discs, and I'll speak about this in a different video, discs have very poor blood supply. In order for things to heal, they require blood. Blood carries proteins, it carries nutrients and electrolytes and all the important things that we need in our bodies. And without a blood supply, the important things that our body uses to repair itself, they're lacking. So think of like your kidney, for example. Your kidney has arteries and veins. Your heart, I know the heart is a pumps out blood all over the body, but your heart has arteries too. Those are called the coronary arteries. So the major structures in our body, the major organs in our body, have blood vessels that feed nutrients to it, not only so it can function, but also so it can heal. It also has vessels that leave those particular structures to take away waste or take away deoxygenated blood primarily. So the disc, though, does not have a very good blood supply. The nutrients of the disc are obtained through what we call diffusion. So the end plates, or the portion of the vertebral body where the disc sits, is what allows diffusion of nutrients to go into the discs, which is not as robust and or efficient as a direct blood supply. So patients often ask, well, doc, I know I have a herniated disc. Won't it just heal and go back in place? One of the analogies I share with patients is, imagine trying to push the jelly back inside of a jelly donut. Once the jelly's out, it tends to be out. Or imagine trying to put toothpaste back into a tube. Because of the consistency of that material, it becomes very difficult to try to put toothpaste back into a tube. And then when you combine that with the fact of a very poor blood supply, the healing potential for discs are very low. So in this particular gentleman's case, he requires surgery. So since we're talking about surgery and not talking about non-operative approaches, we'll talk about 3 of the primary surgical approaches that we often discuss with patients. So since we're talking about surgical approaches today and not non-operative approaches, we'll go through 3 of the common approaches that are likely discussed when a person has a cervical disc herniation. So tried and true, one of the longest operations that we've been performing in spine surgery is an ACDF, or anterior cervical discectomy and fusion. Anterior means going from the front, cervical is the neck. Ectomy, remember, means removal. So discectomy means removal of the disc, and fusion means taking 2 separate bones. So say this is C5, this is C6. We weld it together or fuse it together to become one bone. So that's anterior cervical discectomy and fusion. The second option going through the front could be an anterior cervical discectomy with disc replacement. So the approach is the same. The procedure of removing the disc is the same. The difference is the implant. So when you use a cervical disc replacement, you put a mobile artificial disc in the place where the herniated disc was previously located. When you perform a fusion, you put what we call a cage in its place. You fill it with bone graft, either from the patient or off the shelf, and then you put a small anterior plate on the cervical spine to act as an internal brace to hold things together. So the anterior cervical discectomy and fusion has a long track record, one of the oldest surgeries that we've done in spine surgery, but many patients elect to have a anterior cervical discectomy with disc replacement instead. Other factors have to come into play, sometimes patient preference, but sometimes other issues such as alignment, surrounding pathology, etc. Those are conversations that you can have with your provider. In some cases, depending on the location of the disc herniation, the disc can be removed without a fusion and without a disc replacement. So you can go posterior, which is behind the neck, and do what's called a foraminotomy. So the foramen is the small hole where the nerve lives. So at each level, you have nerves that are exiting on both the right side and the left side of the body. The tunnel where those nerves exit, we call that the foramen. So if you do a foraminotomy, otomy is to cut into. If you perform a foraminotomy, you can see where that nerve is located. And if the disc is in the foramen, you can trim that portion of the disc to relieve the pressure on the nerve and to attempt to prevent the need for a fusion. You can also perform a posterior cervical fusion if the surgeon believes that that's the appropriate treatment. You make a midline incision in the back of the neck. You remove the lamina, which is the bone covering the affected area of stenosis, which means narrowing, and decompress the spinal cord and the nerves. So if there's compression, you perform a decompression. If a fusion is being offered, you would place lateral mass screws in the posterior aspect of the spine, connect those lateral mass screws with rods, tighten those rods down with set screws, and then you fuse the spine that way. You can also decompress the posterior aspect of the spine without a fusion. That particular technique attempts to maintain the motion of the neck while still decompressing the cervical spine. That particular technique is called a laminoplasty. Less frequently done depending on what area you practice, but just so you understand what's available to you if you have a cervical disc herniation. So getting back to this gentleman, DeForest Buckner, if he were to undergo an anterior cervical discectomy and fusion, if the fusion heals appropriately and is solid, he should be able to return to play, at his normal functioning level. We do have case evidence for this. He's been retired for quite some time. But Peyton Manning, Hall of Fame quarterback, he played for the Indianapolis Colts, and he also played for the Broncos. He underwent an anterior cervical discectomy and fusion and still came back to perform at a high level, eventually becoming a Super Bowl champion while playing with a cervical disc fusion, an anterior cervical discectomy and fusion. So the notion that you can't function and get back to life after having your cervical spine fused is not necessarily the case. So you should discuss that with your surgeon if that is a concern of yours. So that's just a brief synopsis of how we approach cervical disc herniations when a patient needs surgery because non-operative treatment is not getting the job done. You can have an anterior cervical discectomy and fusion. You can have a cervical disc replacement. You can have a foraminotomy. You can have a posterior cervical fusion and decompression. And cervical laminoplasty is usually done for more extreme cases of stenosis, but it is a conversation you can have with your provider. Now, downtime and recovery. Well, it takes bones 6 to 12 weeks to fuse. So if you choose to have a cervical fusion, just know, although the surgery will be done relatively quickly, the healing will take quite some time after that. With a cervical disc replacement, you're not necessarily waiting on bones to heal, but you would like the bones to grow into or fuse to the actual implants. You would not want those implants to dislodge because remember, you didn't have a fusion, so you're going to maintain your motion there. You don't want those implants to spit out and dislodge from their normal position once surgery is completed. So there will be a few months of recovery time where we'd ask you to take it easy, refrain from any heavy contact. Again, speaking about this particular gentleman, I do expect him to have a full return to action as long as he does not have any permanent nerve damage. So as always, this is Dr. Claybrooks. This channel is called Real Medicine. Please like, please subscribe, and please share this with someone who may be having neck pain or just interested in sports or anatomy or surgery. As always, thank you so much. Bye-bye.